Hello and welcome to our training today on the institutionalization and criminalization of persons with schizophrenia spectrum disorders. So in today's session, we will be going over some historical evolution. So let's take a look at our agenda today. So we have two major sections. One, we're going to go through that historical evolution of what it's looked like in the past and talk about the history of state hospitals and how that's led into the way that care has been provided in the past and how it's provided today. And then go into a second section on the implications of the care process and how care is meant to break some of the cycles that have happened in the past and really provide a three-legged stool approach, which Dr. Warburton will cover. So let's just go over some learning objectives for today. The goal is that by the end of this session, you will have an increased ability to describe the key inflection points in the history of mental health policy in the US and specifically California, internalize how this history and criminalization of people with schizophrenia impact care, and indicate implications of the care process and apply learnings to current health crisis efforts. So with that introduction, I want to briefly introduce our presenter today. We're pleased to have Dr. Warburton join us. Dr. Warburton is the statewide medical director of California Department of State Hospitals, which has over 6,000 beds and is the largest forensic inpatient system in the country. She's also an associate professor on the volunteer clinical faculty within the UC Davis Division of Psychiatry and the law. And she's board certified in psychiatry and forensic psychiatry. So she has a lot of background and passion for this topic, and we're pleased to have her join us for this presentation today. So with that introduction, I'm going to turn the time over to Dr. Warburton.
Hi there. We have an important update regarding the CARE Act beginning January 1st, 2026. Changes made by Senate Bill 27 will go into effect. These changes include bipolar 1 disorder with psychotic features will now be included as an eligible diagnosis under the CARE Act, except psychosis related solely to intoxication. This law now defines what it means to be clinically stabilized and ongoing voluntary treatment. Certain court referrals can now serve as a care petition. Criminal courts may consider care referrals earlier for individuals found incompetent to stand trial in misdemeanor cases. Nurse practitioners and physician's assistants are now authorized to complete affidavits in support of care petitions, and there are also some technical amendments to streamline the care process. Our training PDFs, including the notes, have been updated to reflect these changes, including the addition of bipolar 1 disorder with psychotic features, and they are available on the CARE Act Resource Center. But during this training video, you may hear older references to schizophrenia and other psychotic disorders, so keep this update in mind that it will now include bipolar 1 disorder with psychotic features starting January 1st, 2026, and other updates made by Senate Bill 27. Thank you for staying informed, and please review the updated resources linked in your training materials. You can find more information about these changes in our SB 27 brief on the CARE Act Resource Center, or email us at info@careact.org.
Thank you so much, and thank you for attending this talk today. I'm going to be starting off talking, next slide, please, about a brief history of state hospitals. I've been working in the state hospital system for 18 years now, and am afraid that sort of this history of state hospitals, which is cyclical in nature, happens to be repeating itself again. So those who cannot remember the past are condemned to repeat it. So I think before we start talking about recent policy changes, we need to understand the contextual history driving those changes. Next slide, please. Prior to the mid-1800s, individuals living with psychotic disorders lived globally in abhorrent situations. For example, they were kept in cages or chained to walls, locked in jails, oftentimes starving and without any type of compassionate care. This changed in the mid-1800s around the world, and this is an example of that change. This is William Alexander Francis Brown, and these are some lectures he delivered in the mid-1800s. And these lectures are remarkable for two reasons. The first is the graphic descriptions of the conditions that people were currently living in, people who had psychotic disorders. And the second remarkable thing about these lectures is Dr. Brown really thought they'd figured it out with the creation of something called asylums, which were large, beautiful, Gothic institutions where individuals who had serious mental illnesses could go and enjoy nature and recover. So his lectures are instructive in that they give the history prior to the mid-1800s and also demonstrate an earnest and sincere attempt to improve conditions for these individuals. Next slide, please. So he was in Scotland, in France. This is a picture of Philippe Pinel, a famous psychiatrist, unshackling someone with serious mental illness from chains as part of this movement. Next slide, please. And here in the United States, we had our own advocate to create asylums. A reminder that at that time, asylums were a good thing, and that was a word with a positive connotation. And so Ms. Dix would go from state to state and document the unpleasant, oftentimes horrific conditions that people with psychotic disorders were being kept in. And she would write a report of her findings and deliver it to state legislatures to try to galvanize change and motivate different states to build these asylums. Next slide, please. In the United States, the asylums were built in a Kirkbride style. This is Dr. Kirkbride, who was a psychiatrist turned architect. And within these beautiful structures, something called moral treatment was delivered. And this is a high point in the mental health history of the United States and the world. So moral treatment really had to do with just treating people with kindness and exposing them to positive, healthy conditions so that they might recover. Next slide, please. Here in California, we have our own architectural examples. This was Napa State Hospital, which is currently our oldest operating state hospital, and this is their Gothic asylum around 1875. Next slide, please. So what happened? Well, these same institutions that were built to deliver moral treatment became overcrowded in time. So in the middle of the 1800s, there were fewer than 150 patients in asylums, and by the turn of the century, by 1905, there were 150,000 patients in asylums or state hospitals. And by the middle of the last century, there were over 500,000 people in state hospitals. And because of the overcrowding and under-resourced conditions in these state hospitals, once again, people experiencing psychotic disorders and serious mental illness were exposed to inhumane, untenable conditions. So the very solution to the issues of the middle 1800s became the problem by the middle of the 1900s. And as I'm going to describe later in this talk, I fear that this trend is happening again. Next slide, please. So things were so bad in the middle of the 1900s that they made movies about just how terrible they were. State hospitals by the middle of the 1900s were referred to snake pits. And this is a picture from a still shot of the movie The Snake Pit, depicting what conditions looked like in a day hall. Next slide, please. And this is a picture of Napa State Hospital around the same time, showing patients in an overcrowded day hall. Next slide, please. Things were so bad in the middle of the 1900s that there were multiple media exposés, and this is our own expose for our state hospital system, of which I am currently the medical director, describing the overcrowded, underfunded, under-resourced, understaffed conditions in state hospitals. And this was around 1947, and so something needed to change. Next slide, please. we weren't alone in California. This was a national problem. And in the middle of the last century, in response to those inhumane conditions in state hospitals, a phenomenon called deinstitutionalization happened. This was an incredibly well-intentioned attempt at changing situation for people with serious mental illness into a humane one. There were multiple factors that contributed to deinstitutionalization. Here in California, it began with the Lanterman-Petraeus Short Act in the late 1960s. Around this time, the first antipsychotic was developed in the form of Thorazine, which raised people's hopes that these symptoms would be treatable enough for individuals to remain stable in the community. There were concerns, fiscal concerns about how much it would cost to actually take these overcrowded snake pits, if you will, and turn them into humane institutions. And there was also a lot of concern about the civil rights and civil liberties of the individuals who had been locked somewhat indiscriminately into state hospitals. So you had both fiscal and civil liberties concerns driving deinstitutionalization. And also at that time, there was an advent of federal reimbursement for individuals in the communities, which provided states with the opportunity to shift some of the cost of care of these individuals. So numerous factors contributing to deinstitutionalization in the middle of the 1960s. Next slide, please. So in this graphic, you can see something I've already talked about, which is the overcrowding over a period of 100 years from the mid-1800s to the mid-1900s. And then in the green bars, I have some literature, academic papers describing what happened ensuing following deinstitutionalization. And I'll talk a little bit about these papers. Next slide, please. The first paper was published in 1939, in which a British psychiatrist named Lionel Penrose described an inverse relationship between the number of patients in mental hospitals and the number of sentenced adult prisoners. And this is referred to as the Penrose effect, Penrose's law, or the balloon effect. This study's been replicated numerous times in international studies. Next slide, please. This is just one study showing the Penrose effect in the United States. You can see that in the dashed line, those are mental hospital populations declining, and you can see the dotted line, the prison populations increasing in an inverse relationship starting around the mid-70s, which coincides with deinstitutionalization. Next slide, please. Another paper that I referenced on that orienting slide was published in 1972 by a Dr. Abramson here in California. And he discussed the LPS Act, which made criteria for involuntary treatment more stringent and based on a dangerousness model, and that was the only avenue left for involuntary commitment was the dangerousness standard, or after a criminal conviction. So in 1970, after the LPS Act went into effect, there was a 36% increase in criminal complaints and over 100% increase in mental commitments due to something called the incompetency to stand trial commitment. So what Dr. Abramson was trying to convey is that he was concerned that former state hospital patients were now being arrested and recommitted to state hospitals under something called the incompetency to stand trial commitment. The IST commitment, as we call it, is when an individual who is so psychotic is arrested, but they cannot understand the proceedings against them and they can't cooperate with their attorney in a rational way. And so they are sent to a state hospital as incompetent to stand trial to be restored to competency. I'm about to explain that this IST commitment has been increasing steadily since the 70s. And starting in around 2013, 2014 in California, this population has exploded. One problem with the IST commitment is while these patients are committed to us in state hospitals, and we are able to successfully treat and restore about 90% of these human beings, we have no ability to interrupt the trajectory that's causing the drivers for the felony arrest and resulting in someone being committed to us. Rather, we just restore them to competency, and then we are statutorily and constitutionally obligated to send that person back to jail to stand trial. So we are not interrupting the trajectory of their disease, and we are not doing any sort of long-term psychosocial intervention. That's important to keep in mind as I talk about the IST commitment over time. Next slide, please. This is another paper from 1989 showing again an increase in incompetent to stand trial commitments post deinstitutionalization. He showed a very positive correlation between IST admissions and deinstitutionalization. And he issued a warning. So this is 1989. He issued a warning that an examination of the nature and operation of an IST commitment reveals its potential to emerge as an alternative to civil hospitalization. Next slide, please. Initially, there was not a lot of quantitative information documenting what Dr. Abrams and colleagues were warning us about in the literature. However, in 2017, the Nashville Research Institute published a study showing from the period of 1999 to 2014, there was a 72% increase in the number of IST committed patients sitting in state hospitals. And as I mentioned a moment ago, our real surge in incompetent to stand trial commitments started around 2014. So this is actually a relatively flat part of the curve. And these populations have been increasing 10 to 20% in California state hospitals since 2014. Next slide, please. This is a national problem. I have a listing of many states where individuals found incompetent to stand trial. These populations are increasing, and state hospitals, frankly, are overwhelmed because the increase is so significant every year. State hospitals can't contend given their limited number of beds. So in these cases, civil liberties groups come in and sue these states to try to get people in quickly, because instead of being able to admit people when they're committed as incompetent to stand trial, state hospitals are forced to have waiting lists because they can't keep up with the demand. And unfortunately, this means people sit in jail waiting to come into a state hospital to be restored to competency. So in general, these lawsuits result in timelines to get individuals into state hospitals. And we find ourselves in 2024 in an ironic position where civil liberties groups are now suing states to institutionalize people. And when you think about where we were 75 years ago, this is alarming. Next slide, please. So I'm going to switch gears for a moment and talk a little bit about the target population for care court, the population that I see in our state hospital systems being arrested on felony charges. And these are individuals who have schizophrenia spectrum disorders or psychotic disorders. And while people who have these disorders make up only around 1% of our overall population, they make up around 15% of the state prison populations, 20 to 30% of the homeless population, and 24% of jail populations. Next slide. So I mentioned the incompetent to stand trial crisis, and just to relate that to the last slide, we have been studying our IST population in state hospitals since 2008. in concert with the University of California, Davis. So we've studied thousands of these individuals. We've examined their arrest records, their referral information, and in many cases, we've conducted full-scale interviews with these individuals. And these are the findings. Fully 67%, or 2/3 of these individuals who have schizophrenia spectrum disorders and who are being arrested on a felony charge are experiencing homelessness at the time of their arrest. So that's 67% of the population experiencing homelessness when they enter the system. Of those, almost half are unsheltered. So we defined unsheltered homelessness as having no access to electricity or water. So these are people who are living on our open streets. We took a small sample of these individuals and tracked them through Medi-Cal utilization data and found that 47% of the individuals who have psychotic disorders who are being arrested on felony charges have not received any Medi-Cal reimbursable mental health services in the 6 months prior to their arrest. And those that do are largely seen in emergency room settings, not in comprehensive treatment. In addition to the IST commitment, not doing anything to interrupt the downward trajectory of these individuals' lives, the IST commitment does very little to serve public safety. 70% of the individuals that are admitted to us, restored, and sent back to stand trial are rearrested within 3 years of discharge. And as I mentioned, referrals for individuals to be restored to competency for felony charge are increasing significantly. Another finding from this study that may not be on the slide is that the criminal justice contact that individuals who are being admitted to us as incompetent to stand trial is increasing significantly. So the percentage of individuals that we admit who've been arrested more than 15 times has increased from about 16 to 46%. So this last bullet represents our hypothesis that the IST crisis is largely driven by individuals who have schizophrenia spectrum disorders, who are unsheltered, untreated, and having increased criminal justice contact. Next slide, please. This is a slide just representing the last data point I mentioned, that more and more individuals being admitted to us have significant histories of previous arrests. Next slide, please. So in 2017, we certainly knew there was a crisis happening in California, but we were curious whether this crisis was happening in other states. So with our partners at UC Davis, we sent out a national survey. We sent that survey to 51 jurisdictions, so all 50 states and the District of Columbia, and had an extremely robust response rate with 50 out of 51 jurisdictions responding. So we feel fairly confident in the results. Over 80% of our respondents noted increases in IST commitments in their state. And when we asked individuals who were responding to the survey, and in general, these were mental health commissioners or people running state hospitals, these were the responses that were ranked highest in importance. And again, the question was, why do you think you're having increased IST referrals in your state? So the number one answer was inadequate general mental health services in the community. Second was inadequate crisis services in the community. Next was an inadequate number of inpatient psychiatric beds in the community. And the fourth highest ranked answer was inadequate assertive community treatment services in the community. So this is a national opinion survey where mental health leaders across the country delineated what they thought was driving the incompetent to stand trial crisis. Next slide, please. This is another study that I just am lifting up given the answers to the survey. that psychiatric bed capacity, and I'm talking about local community psychiatric beds, when you reduced local community psychiatric beds, you saw a significant correlation with an increase in jail inmates in that catchment area. Next slide, please. This is again examining one of the answers from our survey around the opinion that inadequate community hospital beds may be contributing to the IST crisis. This is just showing in California the total number of psychiatric beds and the total number of psychiatric facilities declining from the mid-90s through the early 2000s. Next slide, please. Digging even deeper into this issue of community psychiatric beds, this was from a very interesting paper in the JAMA journal. This study looked at the Organization for Economic Cooperation and Development, which is a clearinghouse for global economic data. And of the 35 countries contributing data to this organization, the average number of psychiatric beds per 100,000 people was around 71 beds. Expert consensus recommendations in the United States recommend that we have at least 50 community psychiatric beds per 100,000 people. In the United States, we have about 22 inpatient psychiatric beds, community psychiatric beds per 100,000 people. And in California, we only have 17 community hospital beds per 100,000 people. So 25 out of 58 counties do not have inpatient psychiatric services. So if an individual is in crisis in almost half of our California counties, there is no place to provide intensive psychiatric stabilization. Next slide, please. This is from that JAMA paper that I mentioned, just correlating the decrease in psychiatric beds with the increase in suicide rate. Just food for thought. Next slide, please. So how might that be related to increasing criminal justice involvement? This is a study of police discretion that indicated when confronted with the choice between arresting a person with mental illness or bringing that person to an emergency room, the most important factor for that police officer was whether he or she thought that the person would be admitted to a hospital bed. So you can see now the relationship potentially between decreasing community psychiatric beds and increasing individuals with serious mental illnesses in jails. Next slide, please. So this is just local California information. This shows the number of beds that we've added to try to contend with the increasing number of incompetent to stand trial patients over the last decade. Next slide, please. And this is showing California data on the percentage of the state prison population receiving mental health treatment. Next slide, please. So I want to take everything we've talked about and relate it now to CARE, the CARE Act. It's really important to understand that we don't have a binary choice between locking people up in mental hospitals and locking them up in prisons. This is a study showing how the Penrose effect, the balloon effect of what happens when people are released from psychiatric beds, like what happened in the United States in the middle of the 1900s. It's actually mediated by untreated mental illness and a relabeling of mental illness behavior as criminal. So this is what we're seeing with the state hospital population. We are seeing people who are untreated and unsheltered being symptomatic in public in ways that may make people uncomfortable. Police are called, as you saw in the study of police discretion. because there's not enough capacity to treat psychotic symptoms, enough capacity to treat psychotic symptoms in the community. Oftentimes individuals are booked into jail instead. So if we want to stop this pendulum from swinging in terms of individuals being locked up in mental hospitals or locked up in prisons, we need to work on this untreated mental illness and keeping people stable so they may remain in their communities. Next slide, please. So here is an idea in action. Please just consider the inflection points in the history of mental health policy in the United States and California, and consider how care fits into that evolution. Next slide, please. So let's look at that. What are the implications for the care process on what is becoming the reinstitutionalization of people with serious mental illnesses in state hospitals under an IST commitment or in jails and prisons? Next slide, please. I hope after the first portion of this talk that you understand our hypothesis that individuals with schizophrenia spectrum disorders are drifting into an untreated, unsheltered condition, that these conditions are leading to increased criminal justice involvement, and that this increased contact is leading to a surge in IST referrals to state hospitals. We know that building more state hospital beds will only exacerbate this problem long term. And we also know that IST restoration is not an adequate long-term treatment plan. And just to reiterate that point, we do stabilize the thousands of people, the thousands of California citizens who are sent to us unable to stand trial due to their positive symptoms of psychosis. However, we're not able to do anything in terms of long-term treatment planning or interrupting the trajectory of social determinants and untreated symptoms that are driving their IST commitment. We are statutorily and constitutionally required to send those individuals back to jail. So what can we do? Next slide, please. We need to break that cycle. And this is just a graphic representation of what we've been talking about. Individuals with psychotic disorders in the community are drifting into untreated and unsheltered conditions. They're getting arrested and having more and more criminal justice contact. As I mentioned, significant increases in individuals with excessive number of arrests over simply a 5-year period. These individuals are waiting in jail at one point, especially during the pandemic, sometimes for months, waiting to come into state hospital beds to be restored. We restore 90% of these individuals, and only 25% stay in state institutions, whether it's a prison term or staying in the state hospital is not guilty by reason of insanity. The vast majority of these individuals have their charges dropped, get time served, or do a little bit of jail time, and then fully 75% of the people we restore are returned to their communities soon after. They're drifting back into untreated, unsheltered conditions, and as I mentioned, 70% of these individuals are rearrested within 3 years, and the process continues. We need to break this cycle. Next slide, please. That's what care is designed to do. That is the purpose of care. Care is designed to break the cycle of homelessness, criminalization, and institutionalization for the thousands of individuals across the state that suffer from untreated schizophrenia spectrum disorders. The population of individuals that I've described who are untreated, unsheltered, who are being arrested on felony charges, care is designed for those people. The success of care, of course, will be based on whether this process can connect the respondent to the right services and supports. And when we talk about services and supports in the context of care, we're talking about the standard of care for people with severe chronic psychotic disorders, and that includes stabilization medications, wraparound behavioral health services, and housing. Next slide, please. Another way to conceptualize what CARE is trying to do is to look at a sequential intercept model. So the sequential intercept model is well accepted in forensic mental health as a way to prevent the criminalization of severe mental illness. Each one of these intercepts represents a point where an individual who has a psychotic disorder might come into contact with the criminal justice system. So intercept 0 is when there's a call to a crisis line. Intercept 1 is when law enforcement gets involved, maybe that 911 call. Intercept 2 is the initial detention or initial court hearing phase. Intercept 3 is when that individual is involved in the court process and waiting in jail. Intercept 4 is when the individual re-enters from jail or prison. And intercept 5 is community corrections, such as parole or probation. So CARE is designed to be an upstream diversion mechanism. So before that individual is involved in the jail and court process, as a way to get that person diverted into comprehensive treatment in the community, rather than continuing on in the criminal justice system. Next slide, please. So how will CARE do this? Well, let's take a look at the statutory criteria for CARE. CARE was designed to help people 18 years or older who have a serious mental disorder in the form of a schizophrenia spectrum disorder and who have severe and persistent symptoms that interfere with their daily functioning. CARE is for those who are not stabilized with ongoing voluntary outpatient care. CARE is designed where participation in CARE is the least restrictive alternative, and for those who will likely benefit from participating in a care plan or care agreement. These individuals are the people I've been talking about, the people who are experiencing untreated, unsheltered conditions, who are cycling in and out of jails, prisons, and state hospitals. Additionally, at least one of the following criteria is required for CARE. The individual is unlikely to survive safely and is deteriorating, or intervention is needed to prevent relapse or deterioration. CARE is not for everybody who has a schizophrenia spectrum disorder. CARE is specifically designed for people who have schizophrenia spectrum disorders who are untreated and at risk for the outcomes of institutionalization, homelessness, incarceration, and premature death, outcomes that we know are happening for individuals with schizophrenia spectrum disorders today. Next slide, please. The goal of the CARE process is to connect an individual with the supports and services in the least restrictive environment necessary to ensure the person's recovery and stability. While CARE lays out a process through a civil court, it's important to note that CARE is about connecting an individual to and prioritizing them for services and supports. This process is about wrapping services around a CARE participant, adapting to their needs and reflecting their preferences. It's also about keeping individuals in their communities. There are various paths into the CARE process. These are the individuals who can refer someone to CARE, including the family, healthcare providers, county mental health providers, first responders, and social service providers. There are also many paths out of the CARE process, including early engagement and county treatment services, or graduation from a care agreement or a care plan. Help continues even after graduation. Ideally, at the end of the CARE process, direct county services continue as needed. Next slide. So when talking about what types of services CARE provides, if you look at the statute, it's really a three-pronged approach that we call the three-legged stool. The first leg are wraparound behavioral health services. The second leg is appropriate housing. And the third leg is stabilization medication. Next slide, please. CARE can break the cycle because CARE can break the cycle by acting earlier to provide support and accountability to individuals with serious mental disorders and local governments. CARE prioritizes those with the greatest needs to help them access resources and services. CARE creates a new pathway to access treatment and support services, and it provides a framework for counties and governments to provide comprehensive treatment and services. Next slide, please. So an idea in action, please consider an individual that has been determined eligible for care. How might the care process improve outcomes related to homelessness, criminal justice involvement, and referrals to state hospitals for persons with serious mental disorders? And now I'll turn it back over. Thank you.
Thank you, Dr. Warburton, and thanks for viewing this training. Again, the goal of this session is that you will have an increased ability to describe those key inflection points that Dr. Warburton described and how that's evolved over time in the US broadly and in California specifically, and then really think about and be able to understand how that has brought us to where we are today and how we're hoping that CARE can break that cycle and apply those learnings to current mental health crisis efforts and really take learnings from CARE to provide more comprehensive treatment for individuals who need it. Just some next steps for you. Visit careact.org for different resources, including recordings of different trainings that walks through the CARE process and can help you better understand what CARE is about. We also have a series related to better understanding schizophrenia spectrum disorders. So we go over schizophrenia basics, evidence-based practices supporting people with schizophrenia, and also go into different details related to course and outcomes and standards of care. So we hope you'll view those trainings to have more information about CARE, what the goal of CARE, and better understand schizophrenia spectrum disorders. There is no wrong door, so if you have a question about CARE, about the process, or want to be connected to county resources, please email us. So in addition to our website, we have our email address, info@careact.org. We may not always have the answer for you, but we do our best to connect you to resources. So again, thank you for joining, and please visit our website for more information.